We're going to be moving on to one of the more severe complications following a distal radius fracture, and that is CRPS. And CRPS, usually you can catch early on, or you can see the symptoms early on if you are aware. And these are the patients that you may see that are coming in where they're doing a lot of guarding. They are having significant pain, so they usually will have pain that might be disproportionate to their injury, and you're like, wow, they really shouldn't be having this much pain. I wonder what is going on. And they may describe like a burning sensation, and so that's part of their sensation. So if they're telling you my hand is just burning, start thinking about CRPS. I don't usually tell the patients like, hey, I think you have CRPS, because sometimes I think that sends them into that worrying stage, and these patients generally already have a really high fight or flight response. So if they're already really elevated, anything that we do in therapy we want it to calm down that fight or flight response, right? So we're trying to like normalize their sensory systems and calm things down. So I'm not like, oh, you're having CRPS, we need to get this taken care of right away. I'll just generally say, hey, I think you're having a little bit of a flare response, and I think it would be helpful for you should go back to your physician and you can talk more in detail, because we know that early treatment with CRPS is key for reducing long-term problems and complications. And the surgeon, you might send them to pain management where they might be doing nerve blocks. There's some other great medications that they're using to treat CRPS. So sometimes even just getting them on those medications early on can be a game changer. These patients might also have vasomotor changes, which I know Josh talked about, but we'll hit on it again. And that's basically when they're having temperature changes in their hand and maybe some skin color changes. So they might have some like molting, but always check the other side too, because sometimes patients just have that in general. But it also might feel hot, or maybe it's not, it feels cool in some areas. And it is normal for a patient's hand to feel hot after surgery or kind of have that intense temperature. However, that should only last for about 4 days. So if they're having a really warm hand after surgery and it's been past that 4 days, you're going to want to think, hey, is there an infection going on, or what's going on? Or if it's longer, further out, then you might suspect more of CRPS, and that's a vasomotor symptom. Now, pseudomotor, which is S-U-D-O, spelled pseudomotor, is more of the edema. So this is where they might have some swelling changes. Maybe there's a significant asymmetry in areas. And this is where you're going to want to make sure that you're really managing the edema early on. So these are the patients where you might be doing the chip clip, or not the chip clip, I'm so sorry, doing the chip bag, which is for a gentle way for edema management where they don't necessarily have to touch their skin a lot, because if they are really sensory heightened, they may, maybe rubbing their hand is just way too much, so you might want to put a gentle chip bag on there to help with the edema. And then motor trophic changes. Motor changes are the decreased active range of motion. They may have a lot of weakness from disuse. They may have a weird dystonia, like they can't do normal movement patterns that you would typically expect them to be able to do. They may have kind of a resting temperature tremor, and they may also have difficulty with more coordinated movements, like maybe like reaching up into the cupboard and grabbing something down is very challenging. And these patients, when you're seeing them early on, you're going to want to make sure that you are trying to get them moving, but moving in a pain-free range. So the worst thing that you can do as a therapist is say, hey, we need to like passively move your hands and get you going, because then that patient loses that any control that they may have. And typically these patients with CRPS already have a poor internal locus of control. So you want to make sure that you're making them in charge of their plan. And so typically what I will do, and what I found most successful with these patients, is to just have them come in for their first visit, and maybe we're just doing deep breathing, and maybe we're just doing range of motion of joints that don't hurt. So you might have them move their shoulders and elbows, but not their wrist and hand, especially after a distal radius fracture. They might not be able to move their hand at all. And that is a very common complication of CRPS, is where they can't move at all. So if they can't, sometimes I'll have them do where they're more like PNF patterns. And that might be where I might have them just cross their body and then making sure they're breathing in and out when they're doing these movement patterns. So that might be all we do on their first visit. And then the important thing is that you provide them with a home program that you and the patient have developed together. So usually on it, I'll say, hey, are you getting enough exercise? So we know that with light aerobic exercise, we generally recommend about 30 minutes a day. And we don't want high intensity because it has to do with the glial cell activation that is common after CRPS. But you want to do light activity. So I usually will say, well, maybe a 30-minute walk around the block, or maybe you just get in your pool and you do some walking around, or if they have a leg bike, they could get on that and do that. So any type of exercise for 30 minutes can be very helpful. This also helps increase the serotonin uptake, which we know is important for CRPS. So that's usually the first thing that we put on their EGP. And if they can't do 30 minutes, maybe they do 10 and they build up to 30. The next thing I might say, hey, what movement do you think you can do within a pain-free range? And it may change from day to day, but they might say, oh, I can move like this much. Okay, that's great. That's better than not moving at all. They might not be able to do all the tendon glides you want, but that's all right. I think you'll get there eventually. So I usually tell them, every 2 hours, I want you to pick a different activity, and we'll make a list together with the patient. And from that list, they check off the stuff that they can and are able to do. And with these patients, I usually have them do a therapy log of what they did and how they responded. And usually the stuff that they're responding well to, we do more of that. And the stuff that they're not responding well to, we kind of stay away from that. There is some research showing that you can do mirror therapy. And so with mirror therapy, mirror therapy is a part of visual motor integration. So visual motor integration can include you're just visualizing the hand doing something you enjoy doing. So you may have them close their eyes and they're throwing a snowball or something like that, but it can't be painful. So all the visualizations need to be done pain-free. The next step of that might be doing some of the laterality changing, or laterality, where they're comparing or they're looking at images and saying, is this a right or a left image? And that can be done through either they're looking at a magazine and they're seeing which hand is right or left and they're saying what it is in their brain, or there's flashcards available. And then there's also 2 apps available called Orientate and Recognize. So those are 2 apps that the patient can download on their phone where they can do that. And then the last one is the mirror therapy, where they put their involved hand inside the mirror and they may be doing exercises with the uninvolved hand to trick the brain into thinking that their injured hand is actually moving normally. There is some studies showing that you need to start with they need to go in a sequential order. I haven't really found that very beneficial, but if you are into that, there's tons of VMI courses available. But I would say that it's usually what's going to work best for that particular patient, especially with CRPS. So you might be just doing visualizations to start, and then you might be going into some of the laterality changing. I will say if your patient doesn't buy in to why they're doing it, it's probably not beneficial. So as a therapist, your job is to educate them on why they're doing it, why you're tricking their brain, and why it is important to do those. And then usually with the mirror therapy, they need to do it several times a day for it really to work too. So that's a part of it as well. One thing I have also found that's helpful with these patients is having them use that hand to do things that they enjoy. So as you're advancing them through the CRPS, and maybe they can do gentle range of motion with their hand, and it's pain-free, then you might have them where they might be, eating popcorn with that hand, or they're practicing opposition. So anything that sends a positive feedback cycle to the brain with these patients is very, very helpful. When you send a negative feedback, you're basically exciting the sensory system, and that's going to be counterproductive. So when you see these patients and you think, I need to do rice, I need to do desensitization, if it hurts your patient, do not do it. You're only going to make it worse. And I think that's where CRPS patients and even physicians will say, hey, no therapy when you have CRPS. It's because they've seen where the patients have gone through these desensitization protocols and things like that, where the patient gets much, much worse. And that's because you're exciting those systems. And that's the exact opposite of what you want to do. You want to get it calmed down, as calm as you can, and then start adding in activities as they tolerate. And having trust in your therapist with this is key. So if they don't trust you, they're not going to want to come in and see you. If they don't see the benefit, if you're not providing the education on why they're there, then they might not want to come back. So your input to their recovery is very important. And I also think with these patients, you don't want to schedule them in a clinic when you are seeing, your clinic is jam-packed with people. There's a lot of like auditory processing that has to occur. So these patients, you really want to keep it a calm environment. So you might be seeing them in a private treatment room. You might be seeing them when the clinic isn't as busy. So there's all sorts of techniques that you can do to keep their sensory systems lower, or as low as possible. If you do have someone where they have the nerve block done, so there is some physicians, I know some pain management doctors that will do the stellate ganglion blocks, and they basically go in and do a block on the nervous system for the arm, and then they'll send them to therapy immediately following. And usually they need like 3 to 6 blocks. And the thing that's good about these is you can do passive range of motion without causing pain. So when they have the block, they don't have pain. So it's a good time to make sure you're keeping the joints mobile. So the stellate ganglion blocks can be helpful for passive stretching. The research is so on it. So I think it just depends on the patient and the pain management doctor. But I will say the most important thing with CRPS is catching it early, sending them for pain management or back to their surgeon, or getting on the phone with their surgeon and advocating for your patient, and then not exciting their system. So calming everything down and making sure that these patients feel in control is really key. If you do suspect that your patient does have CRPS, there is something called the Budapest scale, and that scale, we've included an image of it, but it's basically where they have categories of motor trophic changes, the pseudomotor changes, and then if they have so many in each category, then that's an indication that they have a diagnosis of CRPS. This is usually something that the pain management or the surgeon might do, but we have included it as a reference in the ebook, so you can see it for yourself and just kind of see if your patient is falling into some of those categories.